So dear Greta Ziubryte from Kaunas in Lithuania, welcome you to this this interview, and it's a great pleasure to have you here. And the reason for the interview is your very nice publication in Advanced Interventional Cardiology that was entitled Fractional Flow Reserve, Quantitative Flow Ratio, and Instantaneous Wave-Free Ratio, a comparison of the procedure-related dose of ionizing radiation. And before we go into this, into the further discussion, can you introduce yourself?
First of all, I would like to thank you very much for this kind invitation and opportunity to talk to you. And as you said, I am Greta Ziubryte. I am from Lithuania, Kaunas, and I'm the second year resident doctor in cardiology, working at the Hospital of Lithuanian University of Health Sciences Kaunas Clinics, and working as a young researcher at the Institute of Cardiology of the same university, Lithuanian University of Health Sciences. All these physiological evaluation methods of coronary artery stenosis is one of the main interests of my researchers. Therefore, I focus on them and perform my research in various aspects in this field. So this is my main topic and main interest in interventional cardiology for now.
Yeah, excellent. And we are now, say, a week past the EuroPCR at this moment. You participated also in the EuroPCR last week, in participating from one of the hubs there. We saw you there also on the different occasions. Can you say something about your experiences there with the EuroPCR and participating in this virtual environment?
Yes, it was my third EuroPCI. 3 years ago, it was my first time at this conference and at this congress. And actually, I really enjoyed this year event. Despite it was virtual, but it was very well organized, very focused on really important topics, and they were all these topics were so clearly and properly explained, talked, and discussed. So I really loved this event.
Yeah. You mentioned already that your interest in interventional cardiology and physiology in particular. I think at an earlier occasion we discussed briefly also the setup in your hospital. I believe you do many interventional cases per year in a limited number of cath labs. I mean, you and all your colleagues have been or are extremely busy, I believe. Can you say something again about the facilities, number of PCIs that you do, number of cath labs?
Yes, we have 3 cath labs dedicated only for interventional cardiology. And during this pandemic, we perform about 5-6 PCIs annually. Before the pandemic,
5,000-6,000.
Thousands, yes.
Yeah.
So yeah, thousands. Actually, before the pandemic, the numbers were even greater. I can't be sure about the numbers, but about 7,000-8,000 per year.
Yeah, so those are enormous numbers for the 3 cath labs. So I believe you and your colleagues are very busy the whole day from I guess early morning until somewhere in the evening.
Yes, our working hours starts at the 8 a.m. and ends up at the 8 p.m. So 12 hours per day, every day, 3 labs.
Yeah, no, that's enormous. And that is why you can also have a lot of material available for clinical research, right? You have all the data available. So if we go to your paper that was published recently in Advanced Interventional Cardiology, can you summarize the content of the paper?
Yes, summarizing the results, the main results of this research, I would like to note that we found that QFR compared to FFR and IFR had both greatly shorter fluoroscopy time and extremely lower dose area product in this study. Why this is important? In my opinion, this is extremely important, especially for us, for the physicians working under ionizing radiation facilities, one procedure after another and day by day, because all this ionizing radiation accumulates and may cause really worse side effects for us.
Sure. Yeah.
Nevertheless, in this study, it wasn't discussed and investigated, but in other studies, investigations performed in our study, in our center, and presented at EuroPCR as well, we found that QFR is really reliable and producible compared to both IFR and FFR. So we may count on this method for physiological evaluation and treatment decision making.
Okay, very happy to hear that, of course. And so the study that you carried out was a prospective study. It was a single center. I think all the data was collected between January 2018 and March 2020. Any particular inclusion criteria? You have, as you mentioned, you have there FFR, IFR, and QFR. What was the distribution of these different techniques?
So first of all, as you said, this was a single center prospective study. Inclusion criteria consist of, first of all, of course, performed coronary artery angiography and visually detected intermediate coronary artery stenosis, which vary between 35 to 75% of diameter stenosis. All these procedures were followed by physiological evaluation by either QFR, IFR, or FFR methods. And additionally, what was important in this study that all these vessels were more than 2 millimeters in diameter, and it was intention for treatment in these lesions, in these arteries. And finally, of course, all the data of the ionising radiation must be available, and only these patients with all the data were included into this study. Talking about distribution of physiological evaluation methods, in the first picture you may see that the majority of coronary artery stenosis were evaluated by FFR, and that contained 192 vessels, which consist of about 46% of all study population. 1/3 of all vessels were evaluated by QFR, and in this group were 134 vessels, and the last part of the study population consisted of IFR group. In this group were 95 vessels, and this was 22% of all study.
Yeah, so that is what you can see in figure 1 of your paper. And in figure 2, indeed, you compare the fluoroscopy times between FFR, QFR, and IFR, and indeed. What you mentioned already, that the QFR has by far the shortest fluoroscopy time. It's about less than 50% of FFR, and it's about 1/3 of the IFR approach, and that is of course very important. The fluoroscopy time, as you mentioned, you are in the radiation patient also, but of course you do that day in, day out. And with the multiple patients per day, so it's total fluoroscopy time plus also the radiation dose is enormous importance for you as healthcare professionals.
Yes. Yes. As you said, in figure 1, we can see that in FFR group, fluoroscopy time were almost about 6 minutes. In QFR group, it was almost 3 minutes, and it was more than 9 minutes in IFR group. What that mean? That means that fluoroscopy time was, as you said, half in QFR compared to FFR, and 3 times shorter in QFR compared to IFR. So other parameter which was selected for ionizing radiation detection and evaluation was dose area product. But because we did not include patient's constitution parameters as body mass index or something else, we relied more on fluoroscopy time than dose area product, but nevertheless, dose area product was shorter, lower in QFR as well.
Yeah.
In figure 3, you may see that dose area product was almost, I guess, 600, about 600 grays lower than in QFR, with any significant differences between FFR and IFR and FFR and QFR groups.
Yeah, yeah, that is very apparent from these figures and very well illustrated. So what are, if you look at the study, and of course this is, as we mentioned, single center, prospective, and of course it would be nice to expand it also to multiple centers in the future. But what do you see as limitations of your current study? Is that the numbers, the single center? What do you see as and what you would like to also say improve in future studies?
Yes, of course. As you said, one of the main limitations of the study is that this is a single center study, and what I think is maybe the biggest limitation of the study is that that we did not include patients' constitution parameters, body constitution parameters into this analysis, but we have revised it, and from now on we are including all the data, including patients' body mass indexes, and part of the study was presented at the EuroPCR this year. So we improved the study at this point, and as you said, that the study was a single center study, so we would like to improve this as well in the future, and maybe ask to join other centers as well.
Yeah, so that means also that we should say look at your through on demand on the European website. There you can see the latest figures as you presented it during PCR. And say, given these experiences, the numbers that you present here, what are the effects on your daily clinical practice? Are there any effects already? Do you take these numbers into account? How does this work?
Yes, of course, we perform much more physiological evaluations for our patients since we have QFR analysis. I may say that the numbers increased twice since we introduced QFR into our analysis. What is more important, that physiological analysis performed by QFR really shortens the whole procedure time, because to analyze the coronary artery with QFR takes up to 5 minutes, while performing pressure wire based physiological evaluation methods, this time extends to at least 15 or 20 minutes.
Yeah, okay.
Additionally to baseline coronary angiography.
Yeah.
Sadly, this wasn't included into this study, but as we talked, it might be the subject for another study in the future. So we are going to investigate this as well.
Yeah. So that was also one of my ideas, given your interest and activities
Yes.
into physiology. What are other studies that you have in mind that you would like to carry out?
Actually, I try to look wider about QFR, and for all physiological evaluation methods performed in our center, that means IFR and QFR, I re-evaluate these arteries by QFR and try to collect as many patients as possible with some minor mismatches, because some doctors do not perform the dedicated QFR angiogram, so several patients may be not included. But this is very important for me, because I would like to prove that QFR and IFR and FFR might be absolutely equal on head-to-head comparison, and to making a treatment decision, which is most important for us as physicians.
Yeah. And then, as you mentioned, it may be that if other doctors did not follow the QFR acquisition guidelines, that the data is less usable. But that is, once you are accustomed to follow the guidelines, it is I think it's quite simple. But it's just that you need to think about it. The two views and the acquisition speed. But otherwise, it should be quite simple.
Yes, actually, since I started to perform this analysis, and after all performed coronary angiographies, these projections are really well selected, and they improve our evaluation of the coronary arteries, because we see wider and a little bit deeper. So we are trying to perform as many as possible these projections. And just sometimes some anatomical aspects might cause mismatches.
Yeah, that's what we have heard from other sites as well, that by doing this in a very structured manner, you improve also the quality of your angiograms.
Absolutely.
And even for very experienced interventional cardiologists, it helps to do it in a very structured manner. And so from that point of view, the QFR can also help improve the quality. And I know that you're also your site are very active enrollers for the phase 3 outcome trial.
We are trying our best.
Yeah. So as you know, that is also for us very important that at a certain point in time, based on the outcome, we can demonstrate in a non-inferiority manner that the QFR is at least as good as the FFR as being the gold standard currently.
Yes, I think the outcome of this study will make huge progression in QFR acceptance in clinical practice, as this method is really minimally invasive and in my mind, it has much more process than cons against other two methods. So
yeah, and you mentioned already that in terms of the timing, that maybe the wires may take 15 to 20 minutes in practice. We have published that it takes now 5 minutes, but of course, as a company, we are also continuously improving on the software and simplifying it and automating it, so that also the acquisition and at least the processing time of the QFR will be much shorter in the near future and more automated. So that makes life also a lot easier and distinguishes itself even more from the wire approaches.
Perfect, really perfect. What I noticed in my practice with QFR that in case when coronary angiography is performed following acquisition guidelines, the QFR analysis is really simply, and I need to put several buttons and the result is out. So,
okay.
So this is really, really great.
Yeah, yeah. No, that's it. That's very happy to hear that, of course, from a very experienced user, but also for anybody else and in daily clinical practice, it should be very simple, and that is what we are working towards. Plus, of course, very reliable data, and that will then come with the outcome trial.
Great.
So I think, Greta, we have covered a lot of ground here. I would like to thank you very much for your availability and for your openness in your experiences with the QFR, and we definitely look forward to to further papers from you and your team.
Thank you.
And certainly next EuroPCR we may be there available again face to face and meet each other. And at other interventional cardiology meetings, of course, whether it's virtual or face to face. But again, thank you so much, and I wish you much success in your interventional cardiology research and clinical practice, and we will be in touch.
Thank you very much once again for your kind invitation and really nice interview.
Thank you so much. Thank you. Bye-bye.
Bye-bye.
So, stop.